Okay, it's very high. All right, we are going to finish up with our last speaker for the day. So thank you for your attention throughout the day. Next up, we have Dr. Jill Ehrenreich-May. Jill is a professor and associate chair for graduate studies in the Department of Psychology at the University of Miami. Her research focuses on developing and evaluating transdiagnostic psychotherapy interventions, particularly with a focus on youth. She directs the Child and Adolescent Mood and Anxiety Treatment Program, a community research clinic that trains and disseminates evidence-based practices in youth psychotherapy. And she is an author of the Unified Protocol Adapted for Adolescents, and is also the D&I lead for our local Clinical and Translational Science Institute, and an investigator as part of our course. So we're very grateful to have Jill here with us today. Thank you.
Yeah. Thanks for having me. I feel I feel like I'm turned the wrong way here. So I just want to say this, that I put on this dress this morning and then I got on my way here and I was like, oh my God. I was like, I am telling some kind of subconscious color story to you. This was not planned. This is just that. Yes, thank you, Lang. You can take it. This is just the way it just happened. So anyway, I'm here to tell you about pink and orange, and also a little bit about, I guess, my tale as a lapsed efficacy researcher or clinical trialist, and how I've kind of come to reevaluate even my own work over time and try to think about the work in terms of ways in which it's going to reach more youth in need. So I hope you'll bear with me as I do a little bit of storytelling over this next hour or so. Okay, let's see if I can advance my slides. I'm going to talk about the Unified Protocols for Children and Adolescents. So just some financial disclosures that I make a royalty from the sales of these books, and also get paid for clinical consultation and training and implementation support for this purpose. It's also a focus, obviously, of my research that I'll talk about. And these are some of our funders, NIH, PCORI, IES, Children's Trust, and the Batchelor Foundation currently. So this is a tale about how I got involved in clinical science, really, and doing the work that I did up to date here, and how this was really started with a treatment development focus. My interest in developing a more pragmatic clinical model for evidence-based treatment in youth, and how that has evolved over time to a series of effectiveness trials, services, programs, and very, sometimes purposeful, sometimes not as purposeful, modification and adaptation to improve equity and access. And I'll give you an example of the type 1 hybrid effectiveness implementation trial that we're doing right now in Miami-Dade County Public Schools as well. So I think you're probably familiar with the idea that youth anxiety and depression might be a problem for many, many, many children. So I probably don't have to convince you of that fact. These are very highly prevalent, the most prevalent mental health concerns in youth and young adults. During the COVID-19 pandemic, these problems hit unprecedented numbers. There was a meta-analysis in 2021 which suggested that at least 20% of youth were meeting clinical criteria during the pandemic for an anxiety problem, and maybe as many as a quarter of youth were meeting criteria for a depressive disorder. That's a little bit conflated with when we also typically see the age of onset for these problems as well, so that's hard to control for in some of these numbers. The average age of onset for these problems is around age 11, and they just increase in prevalence over time. And these are internalizing problems, right? So they're not always as obvious to other people when they're occurring, and that might be mistaken at times for being non-impairing. But that's not the case. These are children who are plagued by avoidance, escape behaviors, compulsion, aggression, leading to impairment in developmental routines, with peers, in school settings, with family members, and in the community. And there are certain aspects of these problems that are very, very, very consistent over time. Things like worry and rumination. And so without effective intervention, unfortunately, they are predictive of a lot of future problems, including risk-taking behavior, substance abuse, eating problems, suicidal behavior, and so on. So you would think, kind of given the large need for assistance related to youth emotional problems, that a main priority of our society would be to disseminate any of the many, and I mean many, 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 many evidence-based treatments that have been produced over the last 50 years or so, and contain active mechanistic elements of change. So things like exposure-based strategies, problem-solving techniques, et cetera. Most of this treatment development has historically focused on a narrow band of disorders in a particular domain or a single disorder over time, which makes a lot of sense from an internal validity perspective, right? If you have one set of symptoms of a DSM-defined disorder that you can assess pre-intervention and post-intervention, then you can say a nice story about how your treatment works over time. But we know that most organizations, most clinicians lack the ability to train on any evidence-based treatments consistently. So just picking one problem-specific approach to spend those funds and capital on, as good as the efficacy is for all of these treatments that I have pictured here, it may not be using our training time efficiently. It may not be consistent, of course, with how most youth present or how most clinicians actually even deliver these strategies. So more bad news. The scope of our youth mental health crisis is such that we know that despite these sky-high rates of concern, that many, if not most, of the children who are in need of mental health services are not going to receive any, let alone an evidence-based treatment for these concerns. And although there are many barriers associated with this concern, a key barrier is that the dominant model of psychosocial interventions for youth treatments include one-to-one in-person treatment with a trained mental health professional provided in a clinical setting. And that model, we know, of course, is costly, greatly limits the scale and reach of effective psychosocial interventions, and fails to treat children where they actually are, such as in schools or other high-traffic community settings. And even if we pretended that our evidence-based treatment models could reach youth using these traditional delivery methods, the research, of course, suggests that when we translate evidence-based treatments to non-research settings, they show a demonstrable drop in potency, sometimes at or below what would be expected for a non-intervention comparison or a placebo comparison. This is something that's been somewhat famously called the voltage drop in from evidence-based treatment efficacy to effectiveness. And of course, we know that most providers have not been trained in any of these evidence-based treatments either in their graduate programs, which leads to another problem where when you do want to sort of provide these in different settings, you might be training them for the first time in that particular model. And let's just face it, that even if we could serve the enormous number of children needing psychotherapy with our current workforce using evidence-based treatments, most of our evidence-based treatments for anxiety and depression are derived from an adult-focused model of psychopathology that is based on the concept of some kind of core intrapersonal dysfunction. And increasingly, as has been talked about this afternoon, researchers have called for us to consider the impacts of systemic racism, discrimination, minority stress, bias, and that these are requiring us to reconsider what it is that we're saying that we're treating with these particular interventions that are pitched at treating particular disorders. Finally, as we struggle as a field to implement these interventions, we struggle in particular at getting them out to settings that need them quickly. We need, very much models that for conducting our research that allow us for more dissemination, more rapid dissemination of the work and the treatments to be received by children right now. So these are all conclusions that I came to over time through the work that we've been doing. But I think that it's important to sort of kind of start where we started. a little bit and kind of understand how we came to some of those conclusions, but also what we're trying to do to address some of these issues within our own program of research. So my program of research is generally concerned with this question: can a transdiagnostic approach to youth psychotherapy modulate anyone or some or a little bit, a tiny bit of these limitations to effective care? And a transdiagnostic evidence-based treatment for youth emotional disorders might just make sense logistically. We know that the vast majority, if not all, youth who present for clinical treatment have multiple overlapping problems. And just considering anxiety and depression alone for a minute, anxiety and depression we know share genetic, neurobiological, and environmental risk factors. And at the symptom level, as evidence here in parent and child regularized, that's what I was going to say, partial correlation networks using the SCARED, which is a measure of child anxiety, and the MFQ, which is a measure of child depression, in 467 youth who participated in our research clinic here at the University of Miami and got the UPC or UPA eventually. Depression and anxiety were highly intercorrelated regardless of the informant, although symptom-to-symptom relationships are certainly stronger within disorders, or within clusters of disorder rather than across. But let's just face it, it just makes sense pragmatically. When we look back at like all those great evidence-based treatment manuals that I showed you on that prior slide, when I was working as a clinician, what I would do a lot of times is I would kind of think about the client that I had in front of me, and then I would pull from each of these different books that I had on my shelf, because they were so similar inside that it was pretty easy to combine elements of them. And I used to call this my Franken manual that I was making and kind of building over time with the different good ideas from these different manuals, because most of them had this sort of similar structure where they were focused on first identifying emotion and what it is, as well as affective labeling in the context of emotion, some level of psychoeducation about how emotion impacts behavior and leads to behaviors like avoidance, escape, aggression, compulsions that end up with this sort of reinforcing capacity over time to increase the intensity of emotional problems. And then some combination of cognitive strategies and what Marshall Linehan refers to as opposite action strategies or behavioral strategies to intervene with this cluster of emotional behaviors that somebody might be exhibiting in circumstances where they are not as helpful as they might be in other circumstances. What's different between these different manuals a lot more is sort of how they address caregiver strategies. Some of them, are very youth directed, where maybe they're sort of giving a small amount of time to, the caregiver within session to review what's being conducted in session with the child. Sometimes it's entirely caregiver directed, where there's a mechanistic focus on some element of caregiver behavior. For example, Ellie Leibowitz's SPACE manual focuses on accommodation behaviors in parents of children with anxiety and OCD, does not involve the child at all in the therapy, and by reducing accommodation is finding similar rates of effectiveness to CBT that is youth directed, for example. So there's some variability in this component. I want to acknowledge that we are certainly not the only game in town when it comes to transdiagnostic or multidiagnostic treatments. Researchers like John Weiss and Bruce Torpeda, amongst others, have taken different but sort of similar approaches to this question. But generally speaking, in response to needs for a treatment that address core processes that might be underlying co-occurring emotional problems, the overarching similarity of techniques between these conditions, my research group has developed an intervention that, has cross-cutting focus across emotional disorders. Instead of focusing on circumscribed emotions and situations that just fit within one diagnostic category, our approach, the UPC and UPA, focus on the experience of strong emotions and youth and caregivers' relationships to them more broadly. It does this as well using mostly a modular structure. I'll come back to that point in a minute, and emotion-focused content that allows these evidence-based treatment techniques to be applied across problem area. So the UPC and UPA have 8 core modules. I'm not showing some elements of it here that are kind of beginning and ending points, as well as monitoring aspects that are involved with the treatment. But I want to make the point that really, regardless of how many of these strategies you use with a given youth or in what context, that we believe that they're really targeting putative mechanistic targets, specifically aversive reactions to frequently occurring negative emotions, which we measure most of the time using measures of distress tolerance and avoidance. And we think that movements on these targets should lead to improvements in emotional disorder symptoms. I do want to point out, I'm not going to get into the weeds about the different versions of the UPC and UPA right now, but there are two different versions of the manual. And I'll talk about how that happened. But, in essence, there's a group version for children, the UPC, that has a completely concurrent caregiver component with caregiver mechanistic targets within that. And then there is an adolescent version that is primarily adolescent directed, although the caregiver can be involved in treatment within the adolescent focused treatment as well. Okay, so how did we get here? What were the steps that kind of led to this initial treatment development? Well, I got a K award when I was at Boston University. I remember Steve being in my office back then talking about it. In that K award, we applied the deployment focused model of intervention development, where we were really thinking about iteratively developing this intervention for adolescents at the time. And there were 3 phases to that treatment development process, whereby we were doing mostly quantitative evaluation with a clinical population. So we weren't thinking about getting, perspectives or qualitative feedback at that time. We were just thinking about quantitative evaluation of it, and then iterative development of the protocol. So we did a multiple baseline design study, an open trial, and then I came here to Miami and opened a tiny little research clinic with 1 graduate student and 1 research assistant, and we did a randomized controlled trial somehow. And that randomized controlled trial was small, as you might imagine, 51 adolescents randomized to either receive an 8-week wait list. And why only an 8-week wait list? Well, we were concerned because these were very severe adolescents. Part of NIH's kind of mandate in getting this K award was that they wanted the population to be as naturalistic as possible. That was difficult when you're doing it in a research clinic at a university setting to begin with, but nonetheless, we really did very few exclusions to the sample. So they had self-injurious behavior, they had suicidal ideation, they had other risk-taking behaviors, they were older in age. So at least at the time, it felt like this was a particularly challenging sample. And we compared it to 16 fixed weeks of receiving the UPA. Anyway, long story short, what we found was that at the 8-week point, that the treatment seemed to be more effective than the wait list, thank goodness, but only on independent evaluator measures. And then when we collapsed everybody who had received the treatment using MMLM analyses across the entire time frame, we did see a demonstrable drop. So good compared to nothing. The treatment works. So that's a good starting place, we felt like. At the time, there was a large scale randomized control efficacy trial going on at Boston University, where I had originally been when I was developing this research. And they were comparing the adult unified protocol to single disorder protocols for different anxiety disorders. And we thought this was a really good idea, but it was very difficult with the size and scope of our research clinic at the time to get a very, very large sample to do so. We had been developing the UPC pretty much from the time that we started here at Miami, and Emily Bialik, who's pictured there, and Sarah Kennedy, who's also on here, were my 2 graduate students who worked the most on these projects. And Emily and I actually started doing UPC, this is a fun fact, at the Mini Canes camp. Those of you who are University Miami faculty or students or may know about the Mini Canes camp that happens in the Wellness Center. They do wellness programming, I don't know if you know this, every summer. And so we got to be the wellness programming that they were doing one summer. And we thought, well, let's try out this thing that we've been dreaming up as a universal prevention. So we did that and we thought, okay, well, that worked. Okay, we didn't harm anybody, so good on us. But we really wanted to think about how this might work in an intervention setting more so. So we, again, did an open trial, and then we did this very small randomized control trial. And similar to the much larger trial that was going on at Boston University, we didn't find any differences in terms of anxiety symptoms, whether they got the UPC, which was a 15-session group intervention, or another group CBT intervention that was called Cool Kids, that was basically around the same length, but only focused on anxiety, not sort of this general emotion regulation focus that we had. But we did find some tempting other differences. We saw, for example, that reappraisal seemed to be different with this particular intervention, as well as sadness dysregulation, at least reported by parents. There were some other promising differences when we looked out at follow-up points in terms of response rate, which we thought, again, was indicative that we should continue. I want to speak about the model of data collection that we used for the very long period of time, including still here today. So I have a research clinic in the Department of Psychology, the Child and Adolescent Mood and Anxiety Treatment Program. We recruit people to that clinic 12 months out of the year. And whether we have research funding or not at the time to be able to examine the UPC and UPA. I'm going to talk a little bit more about the sustainability of that kind of model, but it is very much a labor of love that really is built upon the idea that we also provide a lot of graduate student training through this clinic as well, who also provide treatments within the context. So kind of a traditional model, but over time, the clinic just built and built and built and built, and more and more and more families and children were finding us. Now we see, probably about 150 children a year for treatment, but we screen probably something along the lines of 500 to 1,000, depending on the time frame. Certainly post-COVID, we were inundated in a way that was unsustainable. But it allows us to ask a lot of questions about the treatment, at least within the course of implementation in this particular type of a setting. So for example, we were able to ask questions about whether baseline emotion regulation is predictive of different latent profiles to response. And in fact, we did find that the majority of individuals fall into this kind of moderately dysregulated group that has a more average response. About 25% are a more highly regulated group that has a more accelerated response, and then about 10% have a kind of a more challenging emotion regulation profile at baseline, or are going to be more likely to have lesser response, in which case we might need to modify the treatment based on these emotion regulation factors. This is also supportive a little bit of the theory of change. So what was I learning from these small scale studies that we were doing initially in this kind of standalone research clinic setting? One, I feel like small studies, when you are developing an intervention, iterative small studies really do matter. I think Sylvie said earlier that your intervention is not going to be static. We waited a long time to publish this intervention because we really wanted the wealth of experience behind it to be able to tell more about how to actually implement the intervention. And I think doing all of these small studies really helped with us understanding and refining the intervention. But we weren't necessarily testing it with intentionality. We were testing it with convenience, and that was still hard work to do. Don't get me wrong, but with the convenience of whomever kind of came to us. And as time went on, we really needed to think about how to position ourselves as a community resource to all youth in the community, not just the more privileged, wealthy youth who were going to find us first. I think the other thing that we learned in some of this initial efficacy work is that although there was a theory of change articulated for the adult version of this intervention, that theory of change may or may not work, in a developmentally sensitive adaptation, and that we needed to be humble to think about what other factors are core to our theory of change as well. Now, in a perfect world, back in the day when we all did clinical trials, the thing you would do after you have a small scale study on the efficacy of your treatment is a bigger study on the efficacy of your treatment. However, At that time, NIH kind of decided that they sort of knew enough about CBT, and that getting a larger grant to study this on a bigger level, was not necessarily going to be easy to do, like your traditional R01 mechanism, to just do a larger scale efficacy trial. So we started to think more about what else we were interested in understanding. And my interest really was in thinking about how this would work in more traditional clinical settings and not just our sort of more rarefied research clinic that we had created. And so at that time, Golda Ginsberg, who was a visiting scholar with us, she's a professor at University of Connecticut, and my colleague here at Miami, and the mentor of some of the people in the room, Mandy Jensen Doss, and I decided to apply for the very first round of an R01 mechanism that was looking at multi-site effectiveness trials in community settings. And somehow we got this grant on the first round, which was which was really nice, but at the same time, also a little scary because probably the methods needed to be refined a little bit and not quite so efficacy trial oriented. Mandy said, I'm not allowed to do this, to just like immediately tear down this study. So I'll try to stop. I'll try to stop doing that. She doesn't like it when I do it. But anyway, because it is actually the largest scale trial for emotional disorders in adolescents that has been done in community settings. And so it really was a feat to pull off across these clinics. So just to tell you about it very briefly, there were 193 adolescents recruited. They were randomized across 19 community mental health centers in South Florida, and in the Connecticut area. They were randomized within clinic to either receive treatment as usual, so the treatment they would have normally been provided, what we called treatment as usual plus, which added a measurement-based care condition using a measure called the Youth Outcomes Questionnaire, or what we called the UPA condition, but was actually a combination of receiving the UPA and the measurement-based care condition. We did not have a fully factorial design, so we don't know what just UPA alone would have looked like here, because the size would have become really unwieldy. So just to tell you how naive I am, here I go again. When we proposed this, we thought we were going to need 9 clinicians. Does anybody have a guess how many clinicians were in the study? Not you two. 173 clinicians. There were 173 clinicians in this study, because turnover at these clinics was such that the minute we would train somebody, they would either leave, or if they were good, they would get promoted. So the modal number, and they were paid nothing, these clinicians, I mean, just going to people's houses, doing 2-hour sessions for $30 an hour. I mean, it's ridiculous. And so I didn't blame them for going. It was a little sad because then we had to, train somebody else. But that meant that on average, people had 1 case in the study. So this was just basically a study of people doing this for the first time, really in all cases. So what did we find? Well, bottom line is that what we found was that across these different conditions, all adolescents improved. So whether they got treatment as usual, whether they got the measurement-based care, or whether they got the combination, everybody improved. So that was great. But it didn't really tell us much differentially about, whom improved under what circumstances with what treatment. So we've looked at moderators, we're looking at mediators as well. Some of these papers are under review, so I don't want to spoil everything. But in essence, we found that, for example, there are some secondary outcomes which suggest that the UPA outperformed treatment as usual, particularly when they had lesser number of sessions. So when treatment needed to be more efficient over time, the evidence-based treatment seemed to be helpful. The other thing we recognized is that a lot of the treatment as usual included a lot of CBT, depending on which clinic we were using. So we're spending a lot of time looking now also at qualitative interviews with the clinicians to better understand points of fidelity and departure with these various interventions, including the measurement-based care condition as well, because fidelity overall was good, but what they used from the intervention was often very selective. And what they would not use was exposure therapy. There was very, very, very little exposure therapy. And I was the consultant. I personally did the consultant, so I'm to blame, for this. No matter how much people would say, yeah, I'm going to do this, and we problem solve and come up with an exposure plan. Very little to almost no exposure therapy, which, of course, we think probably is one of the most, important elements of these treatments. So what did we learn? Well, one, trying to replicate an efficacy study in an effectiveness context probably is not going to work. For example, we used the ATIS in this study, which is a 4-hour interview. And so we were doing 4-hour plus interviews with participants. So the burden was very high. We didn't do any stakeholder interviewing ahead of time to understand whether, say, for example, did they want to do randomization within clinics versus whole clinic randomization? Because we were randomizing within clinics, we don't know, people didn't get very much implementation support for what they were doing. In some cases, their supervisors weren't trained in the intervention that they were using. So they were very dependent on the consultants themselves. It's kind of like a miracle we found anything when I start talking about it like this. And of course, we did not obviously anticipate the turnover that we got of the staff in these places, but it is inevitable. And I think that should be anticipated when you work with community mental health sites, in a way also about that it has to be a story also about incentivizing people to participate. And if they don't want to participate, that's okay. Understanding why they don't, understanding, what points of departure they use, that's going to be our focus moving on. And we've taken these lessons into 2 other effectiveness trials that we've done and trying not to replicate the same mistakes over and over again. So the first of these studies that I'll talk about is the ProCare trial, which is a trial that we just completed in Spain. This is with my colleague, Luis Joaquin Garcia Lopez. And this had 225 adolescents who were randomized to receive a 10-session version of the UPA versus a kind of a UPA plus, which they call ProCare plus in this particular case, versus an education and support condition. In this case, they did extensive work with stakeholders, with youth advisory boards, with the clients, and then we got ready to do it and COVID hit. So this was meant to be a school-based trial originally, and we had to pivot the entire study to telehealth. And in doing so, I think that the opportunities for engaging in the ProCare Plus elements became really interesting. In ProCare Plus, people identify risk factors at the baseline assessment that may need additional time in session. So things related to bullying, social exclusion, discrimination, dealing with stress, which became dealing with COVID related stress, unhealthy habits, caregiver concerns, and so on. Again, what we found here was that the ProCare Plus condition actually outperformed the other 2 conditions, although the UPA alone condition also outperformed education and support. Additionally, we just completed a recent effectiveness trial with 153 youth in community settings in Portugal. These were done in community clinic settings as well as in hospital-based settings. There was extensive pre-implementation work here where to adapt the treatment to fit using kind of fewer caregiver sessions, a mix of in-person and digital sessions, with clinician support in between the sessions. And in this case, kind of learning from sort of this sort of maybe a little bit of a need for extra support in the initial phases of the intervention. One of the study clinicians that was affiliated with the study team went out and helped them with the initial group that they were doing, and then would kind of pull back their involvement over time. And in this case, UPC, and now maybe it's an age thing because this is the younger children group, but outperformed our psychoeducational condition in all cases across all measures in this particular case. Actually, it's a really lovely version of the intervention with great digital sessions. And we also were able to look at mechanisms within the caregiver group and found that one of our foci, overprotective behaviors, also significantly changed over time for the UPC group. Okay, so we've kind of developed all of these really nice effectiveness trials now of the UPC and UPA that seem to be telling a story that with adaptation, modification, integration, with and interaction with implementation factors, that we are seeing better and better effects of the treatment over time in comparison to at least some credible comparison conditions. But I kind of originally started doing this research in a research clinic embedded in the psychology department. And so when I was able to sort of develop my own lab, at UM, we found that this was a program that was being valued by the community. The idea of like having it taken away just because we weren't doing efficacy trials anymore was, to me, like emotionally and morally a problem, because I didn't have a lot of confidence that these youth were being served elsewhere, particularly at low to no cost in our community. So once we got added to, say, like the California Clearinghouse of Evidence-Based Practices and some other units that sort of catalog these treatments, we advocated with a local a publicly funded parenting and family directed service mechanism at something called the Children's Trust, which is a taxpayer and referendum supported children's agency here in Miami-Dade County, to be part of the sort of funded treatments that they would support. And so we were lucky enough this last year to start into this new era of being funded by these services grants. And we're funded by them as well as the Bachelor Foundation. And between the two funding sources, we're able to provide services to 150 children a year for free. And, while we're doing so, we also really have a strong mission, especially through the Bachelor funding, to train community clinicians to use these practices as well. So we provide free trainings and support through these mechanisms as well. So that's something, right? But I think that, obviously this is a program about improving equity. And so I want to speak a little bit about how at least others and then ourselves have worked to try to improve the equity, relevance, and access to this treatment through adaptations and modifications that have been done. Perhaps because it has this general emotion focus, people have really enjoyed adapting this treatment from pretty much the second that we wrote it. In fact, Sarah Kennedy and I wrote a book about all of the adaptations of this in 2021. It has been adapted for use as a program strategy for PHPs and IOPs, for residential settings for youth, including those who are maltreated. It's been adapted in multiple languages. And it's been tested with a variety of patient populations, including those who have early onset serious mental illness, for irritability, for other specific types of problems. Now, what are we treating when we're using this protocol with different populations? Even with that adaptation and modification, we're still probably aiming at reducing these emotional behaviors, that avoidance, escape, aggression, compulsions that might be happening within the course of these other types of problems as well. So just to give you an example of one type of adaptation that's been done during COVID, we delivered a 6-session version that to only caregivers, where we were focused on doing so on telehealth. These were sort of really exposure-focused sessions that we were doing, and really training the parent to kind of work with their child to use exposure therapy strategies at home. We saw a lot of positive effects of this very brief treatment. I think whenever you make your treatment very brief, it's really important to look at the satisfaction and acceptability data, because nobody's going to tell you, no parent's going to tell you that, like, hey, that was plenty. Like, I'm done now, and I really like that you didn't treat my child directly either. So nobody's going to tell you that. But I do think what they did tell us was that they felt more confident to be able to support their child's strong emotions at home. My colleague Jessica Schleider and I have a grant through NIH to utilize the specific modules of the UPA in a single session intervention model digitally online. And so the way in which we're hoping to employ these strategies to reach more youth is through a variety of different mechanisms. So these could be used adjunctively if you're a therapist and you wanted additional digital modules. But what we're hoping to do is use them on for youth who are waiting on some very long wait lists to receive mental health care, to see if getting access to these materials, if they'll utilize them, which they'll utilize, because adolescents could pick and choose. They're really meant to kind of stand alone and see how they might perform. And we're going to do so with a very, very large children's wait list for services at Lurie Children's Hospital in Chicago in this next phase of the intervention study. So former research associate of mine and professor at Massey University in New Zealand, now Alana Seeger-Van Dyke, when she was a postdoc with John Pachankis, started adapting the UPA to a treatment that is called Empowering Queer Identities in Psychotherapy, or EQUIP. We know that LGBTQ plus youth experience disproportionately high rates of mental health concerns, and that this is typically explained by minority stress theory, that these unique stressors related to discrimination, internalized stigma, plus general life stressors, are leading to what appear to be higher rates of mental health concerns. Many people in this room worked on the adult version of this adaptation model, including Steve Safran and Audrey here. These are some of the enhancements and adaptations that they made, really kind of going very methodically through the sessions and identifying minority stress as the focus instead of a particular, problem or emotion. They're really trying to change that problem-focused language, adding a module on assertiveness, and acknowledging the source of that stress throughout. What Alana did was do a developmental adaptation of that minority stress content, and also adapted to a group format. 10 sessions. This was also tested initially during COVID, so it was also online, but meant to kind of increase social connectedness. Added this identity exploration activity, this gender unicorn activity, created new caregiver handouts. I know the caregiver component is something that she continues to work on and think about. And I really love this. She added this section of each session whereby in the beginning, they talk about LGBTQ plus role models with the group for a little while. And she calls this the Queeros section. And has like all of these great visuals to kind of support it as well. So big shout out to Alana. And she's working on a much larger scale study of this in New Zealand, working with Rainbow Indigenous youth in New Zealand to kind of also further adapt for that population as well, and to look at these outcomes on a larger scale. Okay, so with the 5 minutes that I have left, I'm going to talk briefly about our hybrid effectiveness implementation study that we're doing right now. So I guess what I can say through observation of our process through efficacy, effectiveness, adaptation, and modification work is that I never want to do another trial where we don't spend substantive amounts of time with the population we are intending to work with, and really thoughtfully adapting this treatment to fit their needs as opposed to my needs as a researcher. I just don't have an interest in it anymore. And so we have been working through a funded program of research from the Institute of Education Science to adapt this to what they call Title I high schools here in Miami-Dade County. We know that schools are a place in which youth are served most often. And so finding a workable adaptation for this setting is particularly important to us. I want to give a big shout out to my the other PI of the study, Sarah St. George, who I know was here yesterday, and want to credit her also for helping with these particular slides. We had 4 phases of this study. One, to spend time with our community stakeholders in schools to thoughtfully adapt the intervention initially to fit the setting, then to refine the intervention with using quantitative and qualitative feedback from a case series with 14 adolescents, and then finally to conduct a randomized control trial with type 1 implementation effectiveness hybrid design. And we're comparing to services as usual here. I'll explain where in a second. And then finally, we're doing cost effectiveness analyses as well to kind of understand if this is, additionally beneficial from a cost perspective. So the setting we're working with is the University of Miami School Health Initiative. So those of you who are not familiar with Miami-Dade County, we don't really have mental health services embedded in the schools. They have a small mental health team of clinicians, about 60. I've trained them all in the UPC and UPA. That's why I know how many there are. Unfortunately, 60 people are not going to be able to treat children in the 3rd largest county in the United States, or the 3rd largest school district in the United States. So what they do is they refer kids out. They refer kids out to the same community mental health clinics that we had in the COMET trial that I was speaking about earlier. The School Health Initiative is one of the few embedded care settings within these schools that exists in the county. But it does replicate the structure of mental health services that do exist in many other types of counties. So we thought it was a good place to start. They provide integrated school mental health and health care to over 12,000 youth per year in Title I schools. The School Health Initiative team leaders are members of our investigative team. Their personnel are our personnel in the clinical and research team as well. This is Lizzie Polgaron, who heads the mental health component of their services, and Lisa Gwynn, who's the director of the School Health Initiative. So how did working with this particular structure help us with implementation, at least in this very early kind of staged and type 1 type study? Well, they had full-time staff who already had high mental health literacy and were engaged and interested in getting more services to the children that they had and that they were serving. So they were familiar with the intervention. They were motivated around the idea of providing it. They were a physical structure for us to work with, where we could store materials, a private space to meet with children. They were already doing community outreach events, which they were happy to have us participate in and share in the responsibility for. They already had school champions at the schools and had developed trust in their research processes over time. And were able to help us pre-identify students who might benefit from the project, as well as help us deal with risk issues in a way that supported the school environment. I do want to say, I think the biggest factor in working with this existent entity was trust, that they already were trusted by the school staff. So even if the principal changed or the assistant principal changed, there were members of the team at these schools who believed in them and what they were doing and knew that this is the primary point of healthcare access for many of these adolescents and the only point of mental health care access for a lot of these adolescents, and therefore wanted to support the aims that they were doing. And so we obviously benefited from that. We just published a brand new paper on our phase 1 qualitative interviews, but I'll just briefly mention the types of issues that were identified by a variety of school community members. These were adolescents, caregivers, school administrators, teachers, mental health professionals. And what they asked us to do, of course, were to consider the social determinants of health that may be relevant in this particular context, to think about digital literacy, social media issues, to continue to build trust and use a strengths-based approach to our materials, right? A lot of people can think of CBT as a deficit-based model in the way it's presented. So really to think about how to present it in a strengths-based way was very important. They wanted us to, of course, use a culturally responsive practice and individuals who knew the intervention, who were trained in the intervention, who weren't doing this for the first time, like every provider in the COMET trial was doing it for the first time. And they also wanted us to provide the teachers and the staff with more resources for screening and psychoeducation, and to consider doing it during the school day. this was probably the biggest point of feedback, was like, figure this out. How can we do these? Because they're not going to be able to stay. A lot of them had jobs after school or caregiving responsibilities, didn't have transportation to be able to stay or come early before school. That is not the options that we had. So what we landed on, and then to anticipate that there might be low caregiver engagement, I think it was spoken about earlier how diverse the environment is across these schools. We were working with Booker T. Washington High School in Overtown, as well as North Miami Beach High School and North Miami Senior High School. And these are very different schools that serve a variety of youth, a lot of Black and Caribbean youth, a lot of new immigrant, Hispanic and Spanish-speaking youth, across time. And I think that those were factors that we wanted to consider, but we knew we weren't just tailoring to one cultural group or one population. We really needed to think about how to be as sensitive as possible across groups. And, to anticipate that we might not get the caregivers involved in treatment. In fact, it was quite difficult sometimes to even consent the individuals for these studies, as many of you who've worked in these settings know. So version 1 of the treatment was much shorter. We went back down to 10 sessions. We did it during lunchtime, and we provided lunch. And this was something that was universally liked. In fact, my IES program officer likes to say that the lunch is like the whole thing. So we definitely have people getting lunch in both conditions in the hybrid trial that's going on right now. But we really tried to reframe all of the strategies with a strengths-based, culturally responsive frame, and really think about, we probably workshopped, for example, cognitive reappraisal, which a lot of people can feel, can come across as in a way not culturally supportive, or not, especially in the context of minority stress. We really workshopped a lot of these sessions with our youth advisory board to think about, how is this coming across to you? What do you think about this? And try to reframe the materials until it felt maximally supportive in what we do. And we kind of covered a number of these other elements as well. We had behavioral coaches who were often a school champion, often a counselor, or some other school staff member who would meet with the youth outside of this 40-minute lunch period we had with them. To review strategies. Now, originally, we thought that these coaches could help with exposure, because I was thinking back to the comment trial and being like, nobody's going to do exposure. And so I was thinking, like, let's train the coaches to do this. But the coaches, as you'll see, kind of found that direction a little confusing in the time that they often had. And so we had to kind of reframe that. But the treatment worked really well in the case series. As you can see, we got effect sizes very similar to what we've seen in efficacy trials. But again, just 14 adolescents here off the bat. The qualitative feedback that we got from the case series, we thought was really helpful to further refinement. They really liked the group setting. They really liked getting lunch. They liked socializing with their peers. I led some of these sessions myself initially during the case series as well, to kind of really get a feel for it. And there was a lot of fun had. They liked the external motivator of the lunch. We also did some other incentives for various aspects of like doing their homework and participation, but they also wanted us to focus on internal motivation to do this, not just external motivation. The lunchtime was convenient at 2 of our 3 schools, but almost unworkable at the third. So it was not going to work at every school. For example, North Miami Senior High School had a block lunch schedule. So getting the kids at the same time, the same group at lunch was impossible. And then we tried to make it work after school and nobody came. So challenging, but the option that we had. There was a strong preference for the twice-a-week sessions. The kids really wanted to be in the group, and they wanted to come back to the group. And so coming twice a week was important to them. The coaching was helpful, but again, the coaches wanted more structure. They felt like kind of the focus on behavioral practice was too amorphous for them. They liked the content, but they wanted it less bulky. Again, we got reinforcement that we tried to do some other caregiver engagement things, and they were somewhat falling flat. And they sort of, reminded us that just may not change. And also that we needed to think about things like aesthetics and timing. So we refined the intervention to a 13-session intervention. We provided more structure to the coaches to focus mostly on review of sessions and instead of behavioral practice more amorphously. And we split the sessions such that they had one session that was more didactic and another session that was more practice-based. So they got more opportunities to practice and get feedback on the different content that they were doing. And we'll see. We're about a little more than halfway through the trial. Again, the schools have been extremely enthusiastic about doing this study. The kids are bummed when they get assigned to the not UP's condition, which is kind of heartbreaking. We do offer them the intervention on telehealth afterwards, but obviously that's a little bit challenging as well. We just don't have the number of personnel to be able to do additional groups at lunchtime at this point. But we've randomized 44 for our target of 72. We continue to get qualitative feedback from persons as they finish the groups. And I think, overall, this has been thus far, whether it turns out that UPeace is much more successful than services as usual or not, I think to me, it's been a really successful experience in working with and understanding the school context in order to adapt this treatment as thoughtfully as possible and to try to implement it in a way that might be more sustainable, at least in partnership. And I do want to speak, I do think that when you do a type 1 trial like this, having this kind of partnership, it's essential. It's very hard to just walk in the door cold and offer a brand new treatment that needs a lot of qualitative feedback and adaptation without, partnering with an entity that is a trusted entity. And so I think for us, this was a really win-win type of situation. And we think that maybe some of these methods may serve as an example for others who are interested in adapting or applying evidence-based treatments in community school settings. So I started my evidence-based treatment research journey to answer a question about whether transdiagnostic approaches like the UPC and UPA could aid in providing more effective treatment than single domain or diagnosis-specific programs for youth emotional problems. And where are we now? I mean, to a certain extent, one could argue that the base treatment provides similar rates of efficacy to these single problem approaches, and that the answer to further advancing beyond this point lies in these contextually driven personalized applications such as Equip or UPeace, and increasing access via the single session intervention and digital versions. I do think the base model of UPC and UPA has value, particularly as a learning tool for broadly applicable cognitive behavioral strategies. We get a lot of students. I offer my trainings for free to students, and we get a lot of students coming that they find that this is like a good learning opportunity for them to get comfortable with these base strategies to be able to apply. There also may be scale-up limitations in creating so many different versions of this treatment that are specific to various settings and populations. And I think sometimes maybe like thrown away, doing UPA as a whole intervention or UPC as a whole intervention. And then a study comes out, like a recent study just came out that suggested that UPA outperformed TFCBT for COVID-related PTSD during the pandemic, which is like like you could have blown me over, like knocked me over with a feather. I was sort of like, what? But it really sort of begged for me, like the need for a larger comparative effectiveness trial, but also sort of really kind of thought-provoking about what is it that's different about this treatment that might be appealing to traumatized youth, and the way that we sort of frame some of these strategies. Finally, I spent a good deal of my time training and supporting implementation of evidence-based practices around the globe. We continue to pursue these implementation aims and these effectiveness aims, along with updating our existing intervention. Hint, there might be a second version of the treatment in the works, and it's research-based in the near future. But I do think that as we move more globally, really thinking about who our providers are, and whether these are peers or lay health workers, and whether we can use CBT strategies effectively for youth in these communities using lay health and peer workers, I think will be an important next step in some of our research as well. I just want to end by saying that I basically do none of this. So, I'm like the figurehead talking about the work. But this is work that is done by a large team of people. This is just my current team that is supporting this. And this is just the primary graduate students that are working with me. We have, about 15 additional students who work with us in various capacities as clinicians and as additional researchers as well. And so they are really responsible for any good work that we're doing. And I'm really grateful to them. And I'm grateful for you tolerating me talking about efficacy research for all of this time. And thank you. That's it. I guess we have time for questions if anybody has one. Or are you all really tired? I kind of feel like maybe you might be tired. Okay. Yes.
I just have a question.
Oh,
and
am
a
I
question, I guess. So what activities did you do to try to get the caregivers to come, and was there food involved?
Yes. Okay. So we tried a few different things. I've not given it up. We're actually working on another IES grant application right now where I'm like determined to work. Particularly, I've been thinking a lot with another colleague here at UM, Guarda Nicola, who works with the Haitian community a lot more specifically to kind of think about what are ways that we can, frame this work that is appealing and interesting, I think, to the caregivers that we're serving, particularly in the North Miami areas. I think that we tried before school food, we tried after school food, we tried going on like the open house nights where we might sort of expect more. And in some of these schools, the participation in some of those events is still really low. And so we weren't able to get as much. I think what we hadn't done in this type 1 trial, in this sort of initial trial that I think we would need to do at larger scale up points is going out to the community, as opposed to necessarily just staying on the school grounds and hoping that people come to us. So I would say that is the biggest sort of limitation in what we've done so far to try to engage the caregivers. Good question. Yeah.
So this is school age children until grade 12, but in general, has this been extended to 23, 24,
so there's an adult version of the treatment that is, I think about the upper age range with with the adolescent treatment. We tried actually, I've worked with the Student Counseling Center here, for example, before, and kind of using the UPA, I think, depending on sort of the developmental level of the young adult is important. So for example, in some of the adaptations for serious mental illness or early onset serious mental illness, where the age group goes up to kind of the early 20s, people have continued to use the UPA model. Or we have a PCORI grant right now. I didn't talk about a lot of our other studies, but we have a PCORI grant right now with Susan White at University of Alabama, where they're looking at this with a wide range of autistic adolescents and young adults, and that age range also goes wider. So I think depending on the sample and what kinds of developmental and cognitive facets are in place with those particular individuals, sometimes people have elected to study the adolescent version of the treatment with them, and then sometimes the adult version. Yeah.
Not necessarily a question, but a suggestion.
Please.
Have you thought to maybe go to like community centers where Black people or Afro-Caribbeans kind of gather?
Yeah.
Another suggestion might be to connect with faith-based communities, because Black people are the most religious population in the country.
Mm-hmm.
So it's a lot of times I know I have in my work been partner a lot with faith communities, so that might be another.
Yeah, thank you. That's a wonderful idea. In this recent sort of place where we've now been able to receive this kind of services funding in our clinic. We've been able to just literally this week hire an outreach coordinator. So like, although we do a lot, it's kind of still like small potatoes in some ways of what we do. And so we're just kind of building out some of the staff. So we, over the last year, since we've had this publicly funded entity as the supporter for our in-house services anyway, we've actually moved out to some other locations. So we've moved out to Miami Lakes, we've moved out, we're moving out to Overtown right now to deliver some of the interventions. But in doing so, it's really, obviously, as you're saying, hugely important that we're embedded within the community there and that we're building trust within the communities that we're serving. So as we're doing so, we're doing, more outreach activities and partnering more with organizations that are located within these other communities. And so we didn't do it as much with the school-based trial because, again, it sort of felt contained at the time. But I think as we move out with these other projects, it's hugely important. So I thank you for your thoughts.
Who knows for getting school surveys?
I
wasn't traveling there.
when we got this grant, I mean, MDCPS had been really supportive, and then suddenly they were like, "What are you paying us for this trial?" And I was like, I'm like, "Well, we're not paying." We were like doing incentives for the teacher participants and the school participants. We are very lucky that this study has gone as well as it has, and we hope that it continues. I think part of it is also the lack of mental health services that these schools have. I mean, it is profound. I mean, it's hard to believe that the third largest school district in the country doesn't have more resource for this purpose, but they don't. And so I think we've been welcomed in a way that I really didn't anticipate. And it's just kind of inspired us to want to do more. So. Any other questions? Okay, so now everybody can take like a big stretch and like, done. All right, well, thank you all very much. I appreciate your time.